Our next presenter is Dr. Don Hershman. Dr. Hershman serves as the program leader for the Cancer Population Science Program of Herbert Irving Comprehensive Cancer Center, Vice Chair of SWOG and Corp Research Base, and Director of Breast Oncology at Columbia University Medical Center. She has deep expertise in the areas of survivorship, late effects of cancer therapy, health outcomes, cancer care delivery. She's currently a member of the NCI Cancer Care Delivery Steering Committee and co-leader of the SWOG Cancer Care Delivery Committee. So we're looking forward to her presentation on how to measure and improve drug adherence in clinical trials.
So thank you so much, and I want to thank the organizers for inviting me to speak a bit about adherence. We spend a lot of time at these meetings talking about exciting new drugs, but if patients can't get them or don't take them, they're not going to have an effect. And if we really want to improve public health, we need to make sure that patients can actually take the medicines that we want to improve their outcomes. So the problem of medication adherence is a big one, not just in cancer, but globally. And actually, we've learned more about adherence from lots of research that's been done for antihypertensives and cholesterol medications and other medicines for chronic conditions, because it results in huge costs to the healthcare system. They estimate that it results in over $300 billion nationally per year as a result of issues related to hospitalizations, emergency room visits, premature death, and a whole variety of things. So medication non-adherence is a bad thing. And for oncology, it's becoming something that we really have to pay a lot of attention to, because as we've shifted over time to giving more and more oral agents, it's something that we need to think about in a different way. If you look at FDA approvals of novel anti-cancer drugs, you can see in the blue are the oral drugs, really taking a sharp increase over the past 10 years. In the past, when we gave everything IV, I don't think we thought about it as much, but really the future has been a marked increase in oral anti-neoplastics, especially in the breast cancer space. So adherence, just to start off, is a difficult thing to measure. It's not like overall survival, which is a clear endpoint, or even progression-free survival. It's super challenging, and the results can vary from study to study depending on how you look at adherence. So traditionally, many of the studies that have been done have looked at pharmacy-based records, where they can look when patients refill in an integrated healthcare network. It's good because it gives us a sense of delays, but it's become more and more of a problem as patients get automatic delivery, so they may be getting medicines refilled without taking them, and patients are getting 90-day supplies, and so it can be hard to evaluate that endpoint. Traditional studies in the non-cancer space have looked at viral load, blood pressure, cholesterol, some biomarkers to help get a sense of it. We looked at, in one of our studies, urine levels of aromatase to get a sense of it. It's an all or none variable, and it can change over time. So it's useful, but it has the problem of being a single endpoint. You can look at patient-reported outcomes. A true negative is usually pretty reliable, but it overestimates, as does provider report. You can look at patient-reported outcomes, but they don't usually capture incomplete use very well. You can look at electronic pill bottles, but giving somebody a bottle and telling them you're monitoring them has a tendency to change their behavior. And there are opportunities in the future for digital medications, such as been used in Abilify, where you can actually figure out chemically when a patient takes their medicine through a smart device. So just to give you a sense of a patient-reported outcome, these have mostly been validated in patients with hypertension, patients taking a pill a day every day, and it asks a variety of 3 different questions, 5 different endpoints, but usually, patients it has a tendency to be scored as all or none. This is really complex when we're dealing with medications where you take it 2 weeks in a row, 1 week off, other kinds of variabilities of scheduling, but it's a relatively good instrument to give a sense of whether or not patients are missing their medications. So we didn't really know much about non-adherence in cancer until this first publication came out by Dr. Ann Partridge, which really showed, looking at the use of tamoxifen in a Medicaid population. There were only 500 patients that were followed. This is from looking at refill rates. This was done in the early 2000s, showing that 50% of patients were not refilling their medications by their 4th year. I don't know if people really believe this, but this really sparked our attention because we were looking at the same types of things and also discontinuation of chemotherapy. And we had the opportunity to look at a very large data set from Kaiser Permanente, over 10,000 patients total. This analysis of about 9,000 patients on hormonal therapies showed that about 25% of patients stopped taking their medicine, so completely discontinued over the 5-year course, and about 25% took it irregularly, meaning less than 80% of the time. Again, confirming those initial studies that show only about 50% of patients are taking it the full duration, greater than 80% of the time. What's the impact of this? This is from observational data from our group that shows that if you discontinue the medications early, or if a patient's taking it irregularly, it increases mortality. So you don't get the benefit if you're not taking the medicine. These observational studies are always challenging to interpret because there may be other factors that are associated with discontinuation that also are associated with poor outcomes. So it gives us a sense that this may be related, but we always have some index of suspicion. This is a study that sort of looked at that a little bit further and said, well, what if you stop and you restart? And showing a real difference between patients that restart their medications. So if a patient has stopped, you can encourage them to start again, and that can affect outcome. Oops. So the reason I mention observational studies are challenging is this study, which always shocks me. So this is a study where they just looked at the placebo arm of the Women's Health Initiative. So they looked at patients who were adherent to placebos versus non-adherent to placebos. And if you're non-adherent to placebo, you have an increased risk of death, of fractures, of myocardial infarction, and even of cancer death. So we know that these markers of non-adherence are not just measuring the effect of the drug, but also, as I said before, the other factors associated with a non-adherent patient. So what we can intervene on becomes questionable. So as I mentioned before, we've seen an increase in approval of oral anti-neoplastic drugs for breast cancer, CDK4/6 inhibitors, PI3 kinase inhibitors, PARP inhibitors, tyrosine kinase inhibitors, and possibly in the future oral SERDs. There are multiple drugs in these classes, and even drugs like Xeloda, which we heard about in the post-neoadjuvant setting, where we're giving chemotherapy in oral forms. And so as we start to think about these drugs, we need to think about not only are we giving endocrine therapy, we have a tendency to be adding other drugs into the equation. So it's not just measuring adherence to one, but now measuring adherence to two. So this is a study that was done by CALGB. It was a trial looking at oral CMF for elderly patients with breast cancer, specifically comparing it to AC. When the study was designed, the CMF regimen included oral Cytoxan, and they used those MEMS caps to try to get a sense of how patients were tolerating taking their medications. Now, these are patients that agree to be part of a clinical trial. So right off the bat, they're different than the patients that don't agree to be part of a clinical trial. So they've signed a consent, so they're already a step above in the adherence category. Then we gave them they were given a MEMS cap, so it's an electronic device where every time they open the pill bottle, it's captured, so you know when they aren't at least opening the bottle to take their medicine. And the medicines are given to them, so they don't have to worry about picking it up at a store. And even in this setting, cycle after cycle, only about 75% of the patients were taking it as they were supposed to. And if you look at that second column, those blue bars, you can see only 40% of patients on this trial took it exactly 100% the way they were supposed to. And if you look at greater than 80%, only 60% of patients overall. So in the best circumstances, we're not doing so well. This is a study we did looking at patients that were on MA32, which was presented here last year. MA32 was a study of metformin versus placebo. We looked at the patients that were hormone receptor positive, which was over 2/3 of the patients enrolled. And you could see that non-adherence to metformin was higher than placebo, the green versus the blue. But surprisingly, non-adherence to placebo is quite high. I think what we were really concerned about is what happens to the endocrine therapy, and is there a difference between arms in terms of adherence rates to endocrine therapy? And they were pretty poor in both the placebo and the metformin group. Again, these are patients that agree to be on a clinical trial. I think it's important to note that for these studies, we're not looking at global adherence. We're looking at people that stop, discontinuation, because it's been so hard to measure. Most studies only capture if a patient stopped taking their medication altogether. And as you might imagine, factors that are associated are related to the risk of the cancer. So patients that had prior chemo had higher risk cancers, were more likely to be adherent, age, in this circumstance, BMI, and most importantly, toxicity. And patients that had a known adherence, were well adherent to their endocrine therapy, were more likely to be adherent to their metformin. So we can try to capture that in thinking about patients. This is a trial that we've all heard a lot about, the PALACE trial, looking at palbociclib in the adjuvant setting. So in this trial, 42% of patients stopped taking their palbociclib before the 2 years. So a little bit shocking, 42%. You can only imagine how much it is in terms of patients taking it intermittently. They looked over time at reasons, and it's pretty inconsistent. Some patients stop because of toxicities, some stop because of protocol-directed stoppage, but that's the green bar. That's pretty small and consistent over time. A large portion of patients just stop because they don't want to take medications anymore. So when we think about addressing this, we have to address all the different components. But it really brings in the question, did the drug not work because people weren't taking it, or did the drug just not work? And it's hard to assess because the studies are powered for looking at the whole population. So you start to do subset analyses, you may not find a difference. The investigators did look at this discontinuation rate, and they did not find that was a big contributor to the reason why palbociclib didn't have invasive disease for survival benefit, but there is a slight trend, and so it does make you wonder a little bit about what would have happened if this was an adequately powered trial. So other drugs that have been looked at in the adjuvant space, abemaciclib, which is now FDA approved, they've also looked at their discontinuation rate, and you can see the blue is the abemaciclib versus the red, which was the placebo over time. So a difference between the group, but a high discontinuation rate in both. I think what's really concerning in this study is that a substantial number of patients that discontinued the abemaciclib also discontinued their endocrine therapy. And you can see that in the other half of the slide, where you can see that some of those patients stopped both, and 10% of the patients never restarted their endocrine therapy. And that's something I think we have to pay a lot of attention to as we start to increase the number of drugs that we give to this patient population, because the bulk of the benefit they get is from the endocrine therapy. So there are multiple factors that are related to non-adherence. As you might imagine, side effects is the number one reason why patients don't take their medicines or don't want to take their medicines. It's found in study after study, but there are a whole slew of other factors that are associated in terms of medication complexity, beliefs, logistics, and the costs. And just to think about costs, I think it's important to bring up. This is a study that we presented at San Antonio quite a few years back, looking at hormonal therapies and co-payments amounts, specifically in the aromatase inhibitors before they went generic. And slight increases in the cost of the drug affected adherence to the medication. This was somewhat surprising because these drugs, cost about, at the time, about $350 a month. But as we've seen, the cost of oral cancer drugs has increased, logarithmically, and this is a log scale. So if you could see, it goes from up pretty substantially with this curve. Otherwise, we wouldn't be able to fit it on the slide. So you can see, as I just mentioned, abemaciclib, we talked about aromatase inhibitors costing $250 to $350 a month. This drug costs over $13,000 a month. And so the out-of-pocket costs are going to go up substantially when we're talking about drugs that high. And when out-of-pocket costs are high, you deal with other factors related to adherence in terms of patients not even initiating their therapy. And this is a study that showed as you go up in the cost of the drug, you have high rates of what's called prescription abandonment. So we may be thinking we're sending a prescription into the pharmacy with Epic or the specialty pharmacy, but the patients never actually pick it up because they find out what the copayment is going to be and they just leave it there. And so prescription abandonment and non-initiation go up as the costs do as well. And when we talk about adherence, while these other studies have looked at discontinuation rates, it's also important for us to think about access. In addition, we need to think about what happens to all the other medications that patients are taking when we give them 1 or 2 or 3 prescriptions for their cancer. And this is a study that we did that looked at what happens to patients' blood pressure compliance or cholesterol drug compliance after they're diagnosed, and it goes down substantially across the board. Most of our breast cancer patients are more likely to die of heart disease than they are of their breast cancer. So we need to think about medication complexity not only in the venue of what we're giving to treat our breast cancer patients, but in terms of their overall care as well. So there are a variety of different things that have been looked at or are being looked at. It's super challenging. Part of the reason it's so challenging is that it's really challenging to measure that endpoint. But a variety of different things have been looked at in the medication adherence world: education, simplification, clinical pharmacist consultations, cognitive behavioral therapy, reminding patients, and telling patients how important it is. People have even looked at incentives to promote adherence. Many of these interventions have been modestly effective or not effective at all, unfortunately. This is a study that was done in SWOG that looked at text messaging. And text messaging was of great interest because it had been shown in other countries to improve HIV compliance and other things, especially where the thought was that reminding patients might make a difference. So patients, one of the big problems with a lot of the adherence studies is that you'll see in the literature that a study is beneficial because they did a 6-week or 10-week intervention and patients said that they took their medicines more. But what's more complicated is these drugs where we're giving them for 1, 2, 3, 5, 10 years and looking at their adherence over time. This is a study that was done over a 2-year period looking at adherence using twice-a-week text messaging. And the messages were really, if you're having side effects, talk to your doctor. You should take this because it's going to reduce your risk of recurrence. There are options if you feel like stopping, sort of motivational based and educational based messages. And what we found was that lots of patients are non-adherent, but it didn't really matter if you told patients to take their medicines more. So this endpoint looks like really shocking, like a lot of people stopped. Partially it's because we use that biomarker of urine, a negative urine, or if people just stopped coming to their appointments, they were counted. So we found absolutely no benefit to just this passive reminder suggesting that you need to do more than just telling people to take their medicine more. And no matter how we measured adherence in this study, it didn't affect the difference between the groups. So text messaging had no benefit. But you can see wild differences in the reporting of non-adherence rates based on how you measure it. Patients say they don't take it or they stopped about 10% of the time. Physicians say their patients stopped like 20% of the time. If you look at urines, it's like 60% of the time. So, you know, it really makes it important to think about the endpoints that you're looking at, and maybe looking at multiple different endpoints is the best way to do it. People have looked at smartphone applications to help patients organize their medications. For the most part, patients like this. They think that it's easy to learn, especially if you help them get set up, and it increases their awareness of health behavior. This is a study that was done for oral anti-neoplastic drugs, looking at a complex pharmacist-led intervention with an outcome of reducing side effects, discontinuation, hospitalizations, and overall, speaking to a pharmacist on a regular basis seemed to make a difference in terms of improving those outcomes. This is a study that's being done in the Alliance, the Get Set study, looking at text messaging plus looking at motivational interviewing. And patients are randomized to either motivational interviewing alone, text messaging alone, a combination of the two, or usual care. And patients are giving those MEMS caps bottles to measure adherence a little bit more closely. And this finally, or close to finally, is a study being done in SWOG to get at the issue of symptom management using the active symptom monitoring, something that we've heard a lot about in patients with advanced cancer, to see if you can track those symptoms early and treat them early. Maybe you can keep patients on their medicines longer. And this is a trial that we're doing in our institution to really try to get at some of the health equity issues involved in adherence. And we call it digital equity, to give everybody access to the medications, to know how to refill their medications with a smartphone, and know how to contact their doctor, as well as to simplify medications through a virtual pharmacist-based intervention. So lots of things being done to try to help people figure out how to best manage their non-adherence. But overall, I want you to know that this is common. It's a common problem, and increasing as we increase the complexity, and something we really need to pay attention to as we design clinical trials going forward, both in terms of how we assess adherence and how we power the studies around adherence. There are multiple factors that contribute that should be modifiable, but we need to just build on all the behavioral changes, interventions to know that if we make small changes, we may be able to have a big impact on outcome. Thank you very much.
Thank you, Dr. Hershman, for the fantastic presentation. We'll now open it up for questions. You can come to the microphone and ask a question. I'll start with the first one. This relates to what you had presented, that patients who discontinue therapy but start it again, they have better outcomes than patients who don't receive therapy at all. Do you think that's a setting where we can look at newer medications as well, newer endocrine therapy, because it would have a different toxicity profile?
I think that's a great question, and I think there are studies that are being designed that way in particular to look at, if a patient doesn't tolerate their aromatase inhibitor, maybe that's a good place to think about an oral SERD as a replacement. And so, we know that in the blood pressure literature that switching classes is totally acceptable if you can keep patients' blood pressure under control. So I do think that that's something that we can be looking at going forward.
Hi, Paul Chard, Merck. Is there any evidence that patients who don't adhere start to give up on other aspects in their life? Maybe they don't adhere to medication, maybe they give up on exercise, healthy eating, start smoking, they just think, what the hell? Yeah,
well, I think poor health behavior is associated with other poor health behaviors. And that's why you see those results in the Women's Health Initiative in terms of the placebo groups, right? So there is something to that is more, poor health behavior related that affects outcomes, not just the effects of the drug. That's why you see probably bigger differences between the groups than you would anticipate based on the results of the clinical trials.
Thank you.
My name's Tony Blau. I'm at All for Cure. I have multiple myeloma. I take my pills regularly every day, but there are times when I look at the bathroom counter and I look at my pill bottle and I'm trying to remember, did I just take my pill or not? Ultimately it'd be amazing if one of these methods that allows you to measure whether the pill was actually taken with your smartphone or something like that would be ideal. It also seems like those options are probably pretty distant. What are your thoughts?
I mean, we actually had started a study looking at digital medications, and it's actually pretty simple to do. It's like a zinc coating that is inert, and when it hits your stomach acid, it actually can trigger the chemical reaction can trigger your smartphone so you can see if you've taken your medicine. A lot of those companies actually went bankrupt during the pandemic, but that drug was approved to do that with some of the psychiatric medicines, where when people stop, it can become really terrible because people feel better, they stop taking their medicine, and then they become psychotic.
Right.
So I think
it's expense, I
right.
think, mainly the expense
It doesn't
of that.
have to be a huge expense. It just but probably a drop in the bucket compared to some of the other expenses that are associated with non-adherence.
Thank you.
Thank you so much. So thank you, Dr. Hershman, again for the excellent presentation.